Hey guys, Don here. Welcome to Podiatry Practice Mastery. $1 Million Minute. Here I'm going to go over what happened in the practice today. This is a recording of a Wednesday. I had 22 appointments, 0 openings. A couple of good things that I've noticed. First of all, I told you a couple of days ago I did a talk for a primary care group. It's called Charles River here, and they don't really have podiatrists. And so we've already seen some of the referrals coming in from them. It was easier than I thought, but a little bit more of a challenge because we're all so busy all the time to get in front of them. They had a Zoom meeting, so I did a little talk about our practice, about 10 minutes, and my staff said they're already seeing some more referrals. Also, I think things are filling up a little bit more. I don't know if it's because it's January and February is kind of passed away, or our Google kind of business profiles are back up and running. Also, there was a doctor that I had a phone call with him. He was from Michigan, and he has another kind of a senior partner, and they have a typical practice. They do like half day in a wound care center, probably a half day or day surgery, and then the rest of the time they're in the clinic. And he was wanting to add another modality to bring in some more revenue in the practice, and was wondering kind of what modality. And I think if I could pick one, so he's already seeing probably 25 to 30 patients a day. If I could pick one thing that would really bring in more revenue, in my opinion, the number one thing would be a scribe first, only because I can be much more comprehensive in my treatment, and so I can pay off that scribe, and it gives me better quality of life. If you wanted to actually think of a modality that you can buy to put in the office, I would say it would be Shockwave. He asked me a few questions about Shockwave, like how do you learn it, how do you know which one to get. I would talk to the reps. We use the Curamedics, so we have 2 radial M100 machines, and we have one focus Shockwave and one soft wave. And so because we have 2 different offices, I would start with the radial Shockwave and then kind of get used to it. How do you get used to it? Well, you kind of have to practice. That's what I would do, is I would practice on all your patients, practice on all your staff, get confidence in it, go to a conference to see what others are doing, and then even go visit another doctor that's doing it. You really need confidence, because the worst thing is having one of these machines and just having it sit in the corner. Many times I see doctors, they have like lasers, they have shockwaves, they have ultrasounds, they have all these things, Swift, and they're just kind of sitting in the back of the office, and no one's using it. It's usually because there's a lack of confidence in using that type of machine. So if you guys need any help, just reach out to me down at Podiatry Practice Mastery. We'll set up a little phone call. Happy to help in any way I can. Okay, first patient. This was a 9-year-old little boy that got Cantharidin. Second patient was a 58-year-old female, Shockwave number 2 on the first MPJ. So just a reminder, focus Shockwave works to help with bone marrow edema and arthritis. I never say it's going to bring back cartilage, but this patient wanted to avoid doing a fusion of this joint and wanted to avoid any surgery at this point. So we did an orthotic with an extension, and then we did this Shockwave. Next patient was my MVP for most valuable patient for a couple of days ago. This is EPAT number 4 on his Achilles. He had amnio in there, and we haven't done an orthotic yet, but we'll probably do an orthotic down the road. The next one was a patient that I did a nail avulsion. He had kind of a funky looking nail, and we did a biopsy of the skin around the nail, and it's just all irritated, so I just avulsed that nail, and I'm going to see him back I think in about 3 months, just to see how that's growing back. Next was a pre-surgical discussion. This is a female that has a sesamoid injury, a fracture, and we had tried Shockwave a number of sessions, 6 sessions of Shockwave. It really didn't work for her, so we're going to do a sesamoid removal for her. But I also talked to her in my little pre-surgical discussions. If you don't look at my pre-surgical sessions, you can look at them. Go to patientpresentations.com. You can look at them. There's a link. In my pre-surgical discussion, I've added in a Shockwave slide. So, like, how can you help things heal faster? I do think Shockwave helps with the incision. I think it helps with the healing. I did have a really great experience on a patient. I did Shockwave for a Haglund's, and I had to convert it to an open repair, and she just healed so much faster. So I am offering this to patients, and this patient did accept that, so I'm going to set up 3 Shockwaves prior to her sesamoid removal, another 3. We did 6 a long time ago, and I'm going to do another 3 to help with healing. Next patient was a 56-year-old patient. She had, on the right side, she had a bunion. On the left side, she had a bunion with hallux rigidus, and she really needs a fusion of that MPJ. It's been going on for a long time, so I referred her to one of the other doctors here that does a lot more fusions. Now, this whole conversation, I had a talk with my partner yesterday. Like, this whole thing about referring out surgery is, in the beginning, is a hard thing. In the beginning, I thought, I should be doing everything. I can do everything. I should be doing everything. But I'm not the best at everything, and I want to be clear about that. I don't think we can be the best at everything. I'm going to make a joke here, except my partner, he kind of thinks he's the best at everything, which is good. He's really, really good. I think he is, but he's getting tired of it too. I think some people think they're the best at everything, but really the quality of life that I get by referring out some of the bigger cases is a lot better for me. So I'm going to refer this to one of the other doctors that's done a lot more of them, and I think the patient will be very happy for that. But that's a whole other conversation about like referring out surgery to either someone else in your group or another doctor. Next patient, this is a patient orthotic dispensing. And this is I started to use this word for my patients when I'm dispensing the orthotics, and I got this from another doctor. I think he was in Martha's Vineyard. He said to me, I tell my patients, I don't care if you get 2 orthotics or if you get 10 orthotics. I just think a second pair is important to help with compliance. So as I'm dispensing orthotics, I say that. I say that, you're going to get this orthotic. It's feeling fine. I don't care if you get 2 or 10, but I think the second pair would help with compliance. We have a big discount. There's a little coupon in there for $250 off. We'll see you back in 6 weeks. If they're feeling good, I'd recommend getting a second pair of orthotics. So that's a way of getting a second pair for patients. That's kind of what I use, and I have a coupon for $250 off. I did $250 off versus the price of the orthotic, so we charge $600, so they get a substantial discount for that second pair off. Another thing would be for orthotics. I forgot it right now. It'll come back to me. Sorry. Okay. Next was a diabetic foot exam. 91-year-old guy. I did a diabetic foot exam. He had tinea, so the office visit was for the tinea pedis. I did nails, and I'm going to see him in 1 year. Next was a left ulcer. This was a second opinion. Came in, I debrided the ulcer, gave her orders for VNA, set up a vascular referral and a pedorthist referral for a specialized shoe, so she can get back into a diabetic shoe. Next patient was EPAT number 4 for plantar fasciitis. Next patient was a new patient for nail care, and he's going to be set up with my nail technician. Next patient was a 67-year-old. This one was EPAT number 1. Due to posterior tibial tendinitis. He's a big hiker. He got a kind of a UCBL type of orthotic due to his pes planovagus foot, and he's pleased with the orthotics. I had to heat mold them a little bit, so I had to heat him up with a little heat gun and push out a little bit on the distal lateral flange. But other than that, it's comfortable in his boots. He got Shockwave, and we talked to him about either amnio or an AFO. Next patient was an 82-year-old. She is a woman that had an ulcer on the tip of the toe, came in for an ingrown toenail. It was really an avascular toe, and so she had a stent placed by vascular, and now that scab fell off, and so she's doing much better. No follow-up for her, or just like a 3-month follow-up. Next patient was a 67-year-old female that came in for nails and calluses, and she had a bad porokeratoma, so I did lesion destruction on that. I did a nail sample, and we talked to her to take pressure off the porokeratomas, doing an orthotic, so she'll consider that in the future. Next patient was a 21-year-old female for a matrix, and I'm not doing a follow-up, so no follow-up for that. Next was Cutenza number 2 on a patient. I usually say they have to try 3 of them. He didn't see much benefit for the first one, but I say they have to do about 3 to see if they're going to have any improvement. Next patient, this is a nice guy. He's a 95-year-old gentleman. He brought me hummus. That's why I think he's nice. And I set up a couple of things for him. He has an ulcer on the tip of the left second toe. He hit it, autoavulsus nail, needs a vascular consult, has ulcer debridement, and I'm going to see him in a month for this ulcer follow-up. Next patient was a patient with posterior tibial tendinitis from some bad shoes or wearing boots in the wintertime with lack of support. So I gave her some treatments for that, like foam rolling and anti-inflammatories and better shoes. Next patient was a younger patient that needed an IND. for an ingrown toenail. Next was a 52-year-old male, that had midfoot arthritis. So he had kind of dorsolateral midfoot pain, not in the metcuneiform, but the more proximal to that, to like the talonavicular joint and the navicular cuneiform joint region. And I did an ultrasound on him, found out where the pain was, and I did a cortisone injection. He felt much better. I think he said he was riding his Peloton, and he kind of inflamed that whole area. He felt much better after that. Next patient was a 62-year-old female. Has pain to the Achilles. She is on EPAT number 9. So she did 6 EPATs initially, was better for a while, but started to do stairs and then back to school as a teacher and started to hurt again. So she finished her last session, the 9th one, but 2 different rounds, and I'm going to see her back in 6 weeks. And I told her if it continues to be painful, we'll consider a speed bridge to removing the spur and reattaching it with the Achilles speed bridge. Next was a 55-year-old patient. This was EPAT number 3. She has pain to both the Achilles and the plantar fascia. So in some of those cases, I don't charge twice. I just charge them once. I spend a little bit more time with them. So I did Achilles and plantar fascia to that area. And she is status post amnio as well. So she did amnio. And she also got orthotics. Oh, this is the orthotics thing I was going to remember. Sorry. It is that when I'm doing Shockwave for patients, if I'm doing 6 sessions, I find that if I scan them for the first visit for orthotics, they're not comfortable because in 3 weeks they're still having a lot of plantar foot pain. So what I find is I tell them that when they get the orthotics, I say, your right foot hurts. The left foot's going to feel fine with the orthotic. The right one's going to hurt just because your foot's still hurting. So we need to give it time for it to improve. So many times I'm starting to do the orthotics at the 3rd Shockwave, so they'll be back at the 6th one where they start to feel better. So it's just a lot of expectations with orthotics. Same thing with Shockwave as well. There's expectations of how quickly they should be able to wear them, when they're going to be comfortable for them. But to really be clear with patients, if they're having an acute foot pain issue, orthotics I don't find do a great job at taking away the pain. They do a better job at preventing it from coming back or stabilizing things once it's gone. Okay. Once again, hope this was beneficial for you. If you want help with your practice, I have an audit on my website, podiatrypracticemastery.com. There's a little audit thing. Fill out the information. It might be painful, but you'll kind of learn about your practice, things you can improve, and then we'll either get on a call or I'll send you a recorded message or do a podcast about it. Okay. If that would be interesting, just go to Podiatry Practice Mastery /audit.